some folks that have. Good morning, everyone. Thank you this morning for joining the Long-Term Care Ombudsman Community Ombudsman discussion and work group. I wanted to just go ahead and convene the meeting, and wanted to also say thank you everyone for attending. I know a number of folks have hard stops at 11, so we're going to try to keep the meeting moving along. But I will keep the meeting going if there's more to discuss. And with that, I'm going to ask my co-chairs, Rep. McCarty, if she has any questions or would like to say anything and introduce herself again.
Thank you very much, Representative Dathan. I just would like to say welcome to everyone, and I'm looking forward to continuing the discussion that has begun, and don't want to take any more time. Thank you.
Great. Thank you so much, Rep. McCarty. And Rep. Comey, would you like to say anything?
Hello, everyone. Thank you for coming today. We are, I think, really making progress on this issue. And I just want to have a big thank you to all of our additional information that we received today via Heather through the packet. A lot of this is so informative and is I think really helps sort of set the foundation for the discussion that we're going to have today. Thank you.
Great. Thank you so much. We also have a new person joining today who hasn't been able to make it before with conflicts, but she was a supporter of the original bill that we put through Human Services earlier this year, Nancy Fullis, and I'm going to just invite her to give some brief remarks on her support for this role. Nancy.
Thank you, Lucy. I'm someone who over the years has volunteered a lot with kind of the senior population. Starting in my 20s, there's at least half a dozen times I was involved with that group. And I've had a father who was in long-term care for Alzheimer's. So I got a closer glimpse on a more personal level of kind of what it's like to be on the outside looking in. So even though I was there visiting him, there were times when, I'm looking at the way things were done and felt like I wanted to have more of a connection and more of an understanding of the reason behind things and a more personal experience with concerns that I had, whether it was with medication or the level of lack of activity or whatever. So I think, I read through the material that was here, and I think it's challenging, in the current system when there's a lot of operational issues like shortage of staff, and, that impacts people's care. It's not always within our control to do that. But, I like the model that was presented of, hospice, long-term care, and home-based care, and kind of opening that up. But then there's also the challenge of trying to work outside of a facility where everyone's contained in one place. So I'm sure there's a lot of work that's done. I'm looking forward to just listening and learning about where things are at. And if there's something that I think I can really contribute, I'll chime in. Otherwise, I'll just reserve my comments for after, I have a better understanding of where everyone is at with this. Thank you.
Great. Thank you, Nancy, for making the time to join. I know schedules are challenging, but we appreciate your advocacy here. So with that, I'm going to just make sure that if there is any new updates on some of the information that we were talking about in last session that we haven't been able to send to the group, if people would like to talk about that. I know there was an OLR report that was based on the CSL letter and information that was sent out to the group. And there was also the Special Act 19-18 in the report that was sent out with that. I would like to since we are talking about that, before we kind of jump in a little bit more on the pros and cons, to finish our discussion on that, I really wanted to have Mairead Painter, who's our Connecticut State Long-Term Care Ombudsman, chime in here a little bit about those two things that were sent out, giving some background and how this might be fitting into what we're looking at and discussing today. Mairead, if you could chime in, I'd appreciate it.
Sure. Good morning. So the special act that you all received was a request that was made by the legislature to me and DSS to come up with a plan on how we might be able to look at the opportunity to have a community long-term care ombudsman program. I see that Dorian's on, so Dorian worked with me and the deputy commissioner at DSS to, again, that was sort of it's a base plan, not knowing all the parameters that the legislature wanted in place, looking at what is done in other states and how we thought we might be able to support people who were choosing to receive their long-term services and supports in the least restrictive setting. So sort of what we do for them already on the long-term care side and then following them into the community. The projections as far as the number of people and the cost to that. We worked with HR related to the cost, and then the number of people was kind of an estimate with what we look at for our caseload now, and then adding in, I think as Nancy was pointing out, a little, you have more travel, you have more time that you're going to have to be covering areas. And as the position is in place, we'll get a better understanding of how many people use it and what we might need to do. As far as the funding goes, and I had spoken to a few of you about this, the Build Back Better plan does have a community long-term care ombudsman component to it. And we've been hearing for months and months, as you all have, that this was going to move forward. At this time, that piece is still in the Build Back Better, that if a state takes HCBS, so home and community-based funds, that they would have to have a community long-term care ombudsman role. We don't know if that will be defined by the Administration for Community Living, who currently oversees our program federally and decides how we spend funds. We have to wait and see for that. But we also have, we just found out we have other funding coming in the spring, and that will be to go towards, my understanding is we haven't had the exact definition yet, would be to go for assisted living and residential care homes, elder justice, and looking at how we provide services to those individuals. And then there is the Elder Justice Reauthorization Act, which is also in the Build Back Better, that has funds allocated to our program for sort of some of those wraparound services as well. But unfortunately, until that passes and until we get the federal direction, we're just kind of putting in place what we think would be our best option so that we can tell them what we think works.
Great, that's really useful. I know we'll have a little bit more clarity. Luckily, that hopefully aligns with our legislative session, so we'll be able to really think about that. And as Vice Chair of Appropriations, I'll be advocating to hopefully see that go through. One thing I was hoping that you could address, Mairead, is looking at how this is sitting within the within our state government and how this role might be housed, if you will, and some of the points that you need to address about where it needs to sit.
Okay, so currently, and people who have worked with our program have seen our program kind of move around a little bit. And my understanding is that not everyone understood the rationale as to why we were moved from agency to agency. Our program used to sit within the Department of Social Services. However, federally, through the Older Americans Act, there were some changes back in 2016 where they required that we cannot sit within an agency. So an ombudsman program that does oversight and that sort of watchdog role can't sit within the same agency. Although we really appreciate our peers at Protective Services, we cannot be in the same agency as Protective Services. DSS, because they also pay the long-term care communities, we can't be there. And DPH, because they do licensure and oversight, and DPC, because they oversee the homemaker companion. So anybody who has oversight of a group that we might have a role in a resident's support of, we can't sit within that agency. For a very short time, we went to OPM, and then we were very happy when, and not that we don't like OPM, but it just sitting wise, when we were moved here to the Department of Aging and Disability Services, because we really do, I feel that this is the best fit. It's the people we represent. It has worked out very well. And I think having the opportunity to be able to advocate for older adults and individuals with disabilities with the support of our department has been helpful. So on the community ombudsman side, I think the same thing, having it under that umbrella where they have that, we have that autonomy and the ability to really make sure that we're representing people appropriately is important.
Thank you for that explanation. One quick question. With putting it into the Department of Aging, do we have, sorry, I have a very noisy calling here. With putting it into, I mean, looking at the community ombudsman and talking about hospice services and things like that, we all know that hospice care isn't fully restricted to the aging community. And I want to make sure that we would be able to address those within within the Department of Aging as we need to be thinking about the full role of this, as well as thinking about people in the IDD community that are using these services as well. Can you please address that as well?
Sure. So, and that's where I think taking the Department on Aging and having us now joined with Aging and Disability Services. So any individual receiving hospice, I would assume has something happening, right? Even if they are a younger adult. And we currently work with individuals of all ages over 18 that are in a long-term care setting. We do see younger individuals who may have had an accident, a health condition. So we are not just aging. And that was actually a rule that was changed. There was a point in time where the Ombudsman program was primarily focused just on older adults, but that was changed, and we serve anyone in need that has LTSS in those settings. It is not by age anymore. So I would see that on the same for the community side, which is something I think I've brought up here before. That was one of my concerns by saying offering support by just a program type or a service, I think is more complicated than saying anyone who is receiving long-term services and supports would be able to have the option of the community ombudsman and the support, and then whatever their individualized need was or their concern is how we would target the support that they got and make sure that their needs were met.
Okay, great. Thank you so much. I'm going to pause here for a second and ask if people have comments or questions before continuing the discussion. Representative McCarty.
Yes, thank you, Representative Dathan. And excuse me if I have to raise my hand because the little icon's not there. So I just, if I may, thank Mairead for the presentation and for the report. It really did help. We know that this is a fairly complex undertaking to do a community ombudsman program, but I do think there is a need there, and we just need to look at it and try to put all the pieces together so that it works appropriately. But if I may just ask Mairead, because we currently, the ombudsman program that we currently have, I know there have been challenges within the long-term care facilities and meeting all of the needs. And I know Mairead has worked diligently to build up the Ombudsman program, the regional Ombudsman, and the resident advocates. So I'm just curious, as in a program like this, and I think we last session came a little bit together thinking that perhaps a hospice ombudsman would work under a community ombudsman program as an arm of that. So I'm not sure that that was decided, but I think that was a good approach. But I'd like to ask, if I may, through you to Mairead, how many complaints there may have been, because we have some hospice programs within the long-term care facilities, and looking through the report, seeing there were 3,000 complaints that the Ombudsman program worked with. How many does she think, or she may have an idea, that may have been directed to hospice care, so we can get a good understanding of, it wouldn't be exactly the same, but to understand in the wider home community-based services, how many individuals there might be that are using those services that would be particular to a hospice care. Sorry, it's a little bit lengthy.
No, absolutely. I did try to look at that and drill down. One of the challenges we have, so when we get a complaint or a concern, right, it comes in as a complaint, and there might be, it might highlight hospice, but it may be that the person is having a challenge accessing hospice in the long-term care setting. So the complaint itself, I wouldn't be able to tell unless we went through every single complaint. It might be that the person wants hospice and they couldn't get in. One of the challenges we did hear about last year during COVID was that hospice was trying to get in and support and meet the needs of individuals in a long-term care setting, but because of some of the rules and the way facilities were identifying them, they weren't able to get that access. So that would show up as a hospice complaint, but it isn't a complaint about hospice. It's about someone trying to engage that service. So when we look at complaints, it's a little bit different than how you might typically look at them. When a concern comes in about, if it was about, I'm being very broad here because it's come up in Diane's, if it was about, let's say, a hospice social worker, it might come in, we would classify that as a staff concern related service. So it wouldn't show up as hospice. So it would be really hard for me to give you any number around that. I think that would make it challenging. I would say that we offer a lot of support to people as they're trying to make decisions related to hospice. And sometimes the support that we offer is related to family conflict when there's decisions to be made at end of life, because not everybody is always on the same page, and sometimes they don't agree with what the individual wants to do. So although we call them complaints and cases, sometimes it's about facilitating the conversations and resolution more than what you might think of a complaint. And that's the difference between a complaint with us and a complaint to the Department of Public Health, that if it meets a certain licensing standard. I probably didn't answer that
No.
simply as you would like, but that's where, my team does a lot of training in the conversations and how to support people during those times.
Rep McCurdy, please follow up.
Thank you. Yes, if I may just follow up a bit. So thank you, Mairead, for that explanation. Certainly understand how complex it can be, but that did help clarify. Do the resident advocates, are they trained at all with hospice concerns? And maybe just for, maybe not today, but following through, how many of our long-term care facilities have hospice programs? I'd be interested to know that, but I'm wondering, because as we look to broadening this out to home-based services as well, we're going to have a good understanding of just how it would operate, what the roles of all the individuals involved. And I know you did do a nice job in the report in identifying some of those areas, but I'm wondering, would there be a role for resident advocates? Because I know you've had difficulty trying to really build that program currently within the existing structure. So I'm just trying to look forward to what might be some of the challenges. Mairead, if you could.
Absolutely. And I agree, there is training. We are moving to a national training platform through Consumer Voice. So it'll be for our resident advocates, but for all of our team members to become certified, because no one can work with our program unless there's a certified representative of the program. And so there's components of hospice to it, but I would want further training. And so one of the areas of concern that I have in having someone that would just do hospice is that an individual that we're working with may decide that they want hospice at any point. I think in people's heads, hospice is very end of life. We've seen people go on hospice much earlier and be supported very well by those services for a period of time before the very end of life. And so when they're working with one of my team members, one of the challenges we see right now is an individual might be in a long-term care setting and then go to the community, and then they call us for help with something we can't work with them, but they've already established that relationship, that trusting relationship. And so the reason why I'd like to see those regional teams are that people start to develop a relationship with their ombudsman for their region, and that trusted relationship is there. And I don't think there's a time when it's more important than when you're having to make decisions about end of life and care and services. So at that point, I think it would be important that our team, all team members, have intensive training on hospice. I think it's something that we can continue to work on. And we don't see people using hospice as much as I think they could. The education around that, the support for individuals, and when they should be engaging and having those options given to them, that we could do a better statewide, do a better job of educating people about hospice and those services, and then getting that training, one at a national level, but then also here in our state from hospice providers for my team, and we can do I could see some dual training.
Thank you very much. And I will hold back on more comments. I see a lot of hands raised. So thank you, Representative Dathan.
Oh, thank you, Representative McCarty. And just to let people know, under reactions, I know the Zoom is constantly changing. If you click on the bottom bar reactions, there is a function to raise hand there. So it does move around and it keeps us all on our toes. So apologies if people can't find it, but if you try that, that might help. If anybody else has a question, please go ahead and ask. I would like to call on Tracy Wodach.
Thank you, Representative Dathan, and thank you, Mairead. You actually hit some very key points regarding hospice, and especially the data that shows that Connecticut residents don't access hospice anywhere near as much as some of the other states across the country. We do so in a very last minute format, and I think for that reason, your comments about we could get the message out a lot sooner and we can offer the services a lot sooner. That has been our mantra and goal for quite some time. So I want to go back to Representative McCarty's question about nursing homes and hospices. Actually, all nursing homes, by virtue of their license, are required to offer hospice. They don't do it themselves. They have a contract with sometimes multiple different hospice providers to be able to come in and work collaboratively with the nursing home to offer the resident of that nursing home the hospice services, the full complement team of services. So that is a requirement throughout the state. I want to go back to, again, I guess I say this at each meeting, but I do get concerned that we're focusing so much on hospice, and I want to make sure that we're focusing on community needs. There certainly are hospice needs in the community. There are home health providers. There are home care, like homemaker companion agencies that offer services. And then there are the self-directed personal care attendants who offer services in the community. And within Mairead's, the report that that Heather sent out, it talked about 25,000 home and community-based services as people receive services. And that's a very small subset, not very small subset, it's a subset of the overall community-based services provided in Connecticut. Those are the state-funded services. So there are many more that receive private duty, private pay services. There are many more that receive home health and hospice services that are not state-funded. So if we are to proceed with any type of a community ombudsman program, I think it's important for us to really be able to capture those numbers so we know exactly how many, what the population is that potentially could need these services. But it's much larger than 25,000. And I know it's a long-term care ombudsman, but at that same token, how can we possibly have an ombudsman in the community and say, I'm sorry, I can't answer your issue because you're not part of the long-term care aspect of care being provided in the community. So I think that that's something that we really need to look at. And if we're going to do it, I think it needs to be for all. It can't just be for one subset of the population.
I fully agree with you, Tracy. I think you raised some really good points there. I think Mairead may have a response to that, and I would love to let her chime in before going to next questions. Mairead?
Sure. So Tracy, very good point there. And we struggled with that a little bit because the request for the report from the legislature was only for the individuals being served under the Medicaid waivers and those. So that was something, you know, when they asked for a projection of numbers and staff that would be needed, it was specific to that group. And I totally agree with you. How do you say to someone else who calls from the greater community, yes, but not you? So I agree, if it was that larger sort of bloom of people receiving long-term services and support or community care services, that we'd have to look at that staffing piece and know that it might be something we're not going to start with. We wouldn't have a ton of complaints in the beginning. It's something that would probably grow over time and would have to be probably reassessed every 3 to 5 years as to what the needs were. But yes, I do believe that the universe that to be served is probably much larger than that, but the report that we were answering to gave us parameters.
Do you mind if I just ask one other thing? I'm sorry. So in all the work that you've done through the pandemic, Mairead, I know that you were forced to do a good deal of it remotely. Do you envision being able to do something like that in the future as maybe a more efficient way of being able to address many more cases than, and you talked in the report and you mentioned about how you'd also have to account for travel, et cetera. But to me, being able to do something telephonically or even FaceTime, virtual, et cetera, whatever process is set up, I know it may not always be as effective as in person, but it certainly can accomplish a great deal and probably be far more efficient and cost effective.
Absolutely. So 2 things for that. One, we heard back from the Mathematica report that some residents and many family members felt that their ability to access us remotely and in this way was a huge benefit to them. So when meeting with family members, we are using it more even now. However, the Administration for Community Living federally requires that for every case, we must see the resident in person. It must be face-to-face, it must be in person, or it doesn't count as a case. So I don't know how, again, it would depend. They may, now that we've used technology so much and that people are more comfortable with it, and they would be developing the parameters around this at a federal level if they move forward with it. They might take that into account. These are all things that we're having conversations about now and trying to ensure that the individuals who are writing the scope for this understand that there might be times when we could have an individual who's better served or wants to be served remotely, and we would accommodate that. I would want to support people in what works best for them. And so being a resident or an individual centered program, we would ask the individual. And actually for my team members right now, even though we are actively back in every long-term care community, there are still some residents who are very nervous about COVID and don't want in-person visits. And so we are asking prior to going out, if they're comfortable with someone coming into their room and if they want to be supported with a face-to-face visit, or would they prefer to do something like this or over the phone, just to make sure that we're being individualized.
I think that's a good thing. And I would envision that the federal government will be thinking through some of these requirements, because we do need to be, cognizant that everybody wants to keep safe, and some people's comfort levels are different. So thank you for bringing that up. We will be talking to our federal representatives about that going forward. I'm going to call in Teresa Bachhuber because she's got her hand up.
Thank you so much, Representative Dathan, and thank you for guiding us to the hand raise button, because you probably saw my eyes frantically searching for it, couldn't find it. So thank you for that. I actually just a great discussion. Thank you, everybody. But I did want to address Representative McCarty's concern about the nursing homes, and Tracy, of course, did a beautiful job with that. So I won't be redundant. But the one thing coming from a provider standpoint, Seasons Hospice and Palliative Care, is that, if you've got nursing homes out there that aren't contracted with a hospice provider, that would be a concern. Having, I had over 80 contracts with facilities for our territory, but there's facilities out there that say we can do hospice. They can't do hospice. They think they're providing end of life, and they are providing end of life care, but they don't have that entire IDG, interdisciplinary group, interdisciplinary team that they can offer the patient and family or resident and family. So that would be the concern that I would throw out there to anybody, advocating for the long-term care facilities and or hospice out there. So that's all I wanted to add to that piece. So thank you.
So are you referring, Teresa, to like licensure or?
No, hospices, nursing homes rather. There are some nursing homes out there that will say, we do hospice, we don't need you.
Right.
And that, they are, as Tracy mentioned, they are required to offer hospice. And that is all of the different disciplines, including the aftercare, bereavement support. So, so that'd be my concern there, just to throw that out there.
Yeah, that's a really valid concern. If we can have a pause for a second and get some feedback. If you have maybe some feedback on specifically on Teresa's point, I'd appreciate if you can kind of wave in front of the camera, and I will. I'm going to let Tracy. You're waving.
Yeah, I'm sorry. It just.
No. This is
Yeah. Just to clarify even further, when Teresa says some nursing homes say we don't need to contract with you because we offer hospice, they cannot offer hospice because they're not licensed to offer hospice. They're licensed as a skilled nursing facility. So the hospice program is a specific license under both the state of Connecticut Department of Public Health as well as Medicare. So it's a requirement that they have a contract with a licensed hospice provider.
That was my understanding as well. So thank you for clarifying it. But Teresa, you're suggesting that there are still issues out there because of this?
There are.
Okay.
There are. They're few and far between, but they're there.
Okay.
And many times, I apologize, but many times
No,
that
okay.
has to do with the 3-day required hospital stay for people to get their their Medicare benefit in a nursing home. And if they decide to forego the Medicare rehab benefit for the nursing home and go on to hospice, then that resident would be getting full hospice services, but they would need to pay room and board to stay at the nursing home. So it's a little bit of a conflicting, I don't know how else to say it. Sometimes they'll say, well, stay on Medicare, we'll offer you the services so that they don't have to pay their room and board.
Got it. Okay, thank you for clarifying that. I'm going to move on to Diane Lauricella, one of my Norwalk constituents.
Good morning, everyone, and thank you, Representative Dathan. This has been, again, very interesting. I've read the background information. I've been doing some of my own research. One thing I want to recommend, and while many of these long-term care issues, especially the issue that Teresa brought up, have to do with long-term care, I want to keep our eye on the ball of home care, because that need is growing. People are obvious, we all are here because we know that there is that need. I don't want to have I think, for instance, the information that Teresa brought up could be easily resolved with the licensing oversight group. Just get the list and see who has the contracts. But I do think it's a very important issue, but it is not having to do with home care. And I do feel in relationship to Mairead's very important ideas, one thing that I'm very pleased about is a lot of administrative needs are coming up on the table, and that has to do with getting data, because if we don't have the right data, we won't be able to keep funding this very important home need. That means that also maybe built into the legislation that there would be a section on the forms used so that we could refine those forms so that it would be easier to find out what the hospice need is versus something else. And all of these other things are very valid as well. But to refine the forms, when I was a regulator with the government, by just adding one question sometimes helps refine that data so it's easier to turn it into substantiation for funding. And two other quick things. Number one, and this has been a theme that I have stated, and I hope that we can build this into the legislation, that complaints about the type that I had introduced won't happen and don't happen if the public doesn't know how to file a complaint. That has to be kind of like an overriding theme. So therefore, I would love to see if it's possible in subsequent legislation, should this group and Representative Dathan and others think it is worthy, can we have a public outreach component in addition to the provider training component that has been another theme that Tracy and others have discussed? Literally build it into the legislation if possible. And lastly, the name of long-term care ombudsman, while I know it's an established entity, I do think the regular public, including patients, will be not misled, but they won't understand that their issues related to home hospice would fall under that department. So that's more than a semantics issue. It's just a public education issue. So thank you for allowing me to comment.
I thank you, Diane. I think you raised some real valid points. I consider myself a data geek, and I really like to see metrics. I really like to see data supporting this. And as someone who sits on appropriations, it's one of the questions I ask a lot is, what sort of data do we have to support, and how many people are we serving? And, kind of think of the metric, cost per, case or something like that. So that is a really important aspect that I would definitely like to see as part of the legislation. And I do agree with you that we do need to think of a little bit more about public outreach and how we are ensuring that people know about this, whether it's the providers that are actually providing information to families, whether it's, other sort of sources of information dissemination. Does anyone have any response to, apart from myself, about Diane's questions? You can also, okay, I'm going to call in Melissa Morton. She's got her hand raised in both areas. Thank you, Melissa.
Hi, thank you, Representative. I'll start with my direct comment to Diane's comment, and because I agree that outreach is critical. Outreach and education. A lot of times the community just doesn't even know what their rights are, where to turn when they're having a problem, where to find resources. So that's key. The other point that I wanted to address is that education, I think, needs to be around what we mean when we talk about long-term care, because in the state of Connecticut, probably nationwide as well, but particularly in Connecticut, we at the state level have been working very hard to try and educate the community that when we're talking about long-term care, we are not just talking about nursing facilities, but that long-term care is in fact a continuum. So we're actually, when we use the term long-term care, and many groups are starting to move toward long-term services and supports instead of long-term care to try and break that stigma. But we're actually talking about the full continuum from home care to assisted living through to, full skilled nursing care. So it's really going to be an important component of all this to educate the public, providers, everybody as to what we actually mean when we are talking about long-term care. So that was just my immediate reaction to Diane's comments. But I did just want to chime in because I unfortunately missed the last meeting, but in reading the minutes and in the report provided by Marie, I just wanted to lend my support for both Marie's comments and I think Tracy, you also said it as well, the need to really focus on looking at a community long-term care ombudsman program and taking a holistic look at what that would mean rather than carving out one group over another. Looks like last time you guys got on your way to coming around to that. But the one thing that was in Marie's report that I just don't want to get lost because I think it is critical is the important step of doing an asset mapping exercise where we look at all the various supports in the community that address various parts of the long-term care spectrum and might already be involved in providing outreach and education, might be involved in taking complaints and doing providing some sort of case management or assistance to families. And through that asset mapping exercise, we might be able to come up with some great information that identifies where the strengths in the state already exist, where are the resources that are doing a great job, where are the gaps, how can the community long-term care ombudsman serve as a wraparound so that perhaps they're the umbrella, but they're able to bring in and utilize the strengths of already existing community resources so that we are able to not reinvent the wheel where we don't have to. The other thing that, and I'll move on and let others speak, was that I was curious in any research that we've done and what other states are doing, if they themselves went through an asset mapping exercise, but also did they utilize a phased in approach? In other words, just going out and serving the whole community, that's huge. So was there a phase in? Did they do it by region? Did they do it by specific type of service, by carving out just, individuals that self-direct their services through the Medicaid program and then expand from there? I was just interested in how other states implemented that and if a phase in would be a more manageable approach as we move forward.
Yeah, thank you, Melissa. That's some great points that you raised. I'm going to let Mairead respond because I think she's got a better lens on how things are working nationally and what we need to be thinking about in regards to this. But thank you for your question, Mairead.
Thanks, Melissa. Great points, and I agree. The education and outreach about our program, our role, we really learned during the pandemic how important it is that people understand the word ombudsman, what we do, sort of the role, how we serve people. So we know that that's a place where even my current funding, we're putting a lot of effort into education and outreach and support. We didn't pick the word, just sort of has stayed with us since the 70s. But I do understand that point and the outreach that needs to be done. To Melissa's point about not recreating the wheel and the asset map, I really feel like that's a huge need. And we don't want to recreate the wheel. And that's our role right now, even when we have complaints and concerns that come in on the long-term care side in a facility. That's one of the things that we do. We look at, who we should be making the referral to. We don't have all of the tools here within our office. I would say one of the biggest skill sets of my team is understanding those resources. So to Melissa's point, us knowing what Dorian's group does, what other people can do in other agencies. And it's my team's job to connect individuals to those services, because we have a lot of great services throughout our state that are already there. We don't need to recreate them or to provide all of those services, because there's plenty of other places of excellence within our state. We also do that through the Elder Justice Coalition, which many of us on here are team members of. And we've been looking at that, doing cross training so that we know what each other's groups do and when those referrals are most appropriate. And to Melissa's last question about how other states have set up, every state that has a community program has done it very differently. Some only provide services to individuals who have left a nursing home under money follows the person. Some provide services for anyone, even down to very young children across all of the settings, including DDS, DCF. It's a very, very wide program. And then you have some that have set it up like that in little pockets and have either changed their scope or who they serve by what they found as far as referrals. I think Ohio did that. They were getting calls or weren't getting calls and have tried to adjust to that. And now everybody's just kind of talking about it again to see what federally, if we get something, how we think that fits and it'll move forward. All very good points.
Thank you for providing that insight. Just seeing if I can find Melissa. Do you have any follow-on response to that, Melissa, before I call on Nancy?
Nope, that was really helpful. Thank you, Marie.
Okay, great. Thank you, Melissa, for your questions. Those were great. Nancy Folis, I see you have your hand raised. Nancy, you're muted. If you can just take yourself off mute.
Myself. So I'm just following up on several other people who had, I thought, very important things to say, really kind of on the idea of benchmarking and looking at assets and resources that are already in existence and how we can utilize those first. I'm going to just drill into the idea of complaints too, that there's I think it'll be important for this committee to get a better understanding of the scope, the range that, where are the biggest complaints? What are the biggest complaints that are not being addressed through other resources? And like, I think someone mentioned working with families, that often there's family discordance, that you have kids, coming together to try to address the care of their parents. And it can be a very stressful time, I think, for a lot of families. In my case, there was a social worker who met with my brother and my sister, and we all kind of sat down and looked at everything. But if you were not the power of attorney, they really wouldn't discuss care with you. So being the youngest in my family, I was kind of out of that loop. So I think it would be wise to get a better understanding of what the hotspots are in terms of the complaints that are there. And I'm sure that, they're going to cross lines from long-term care, home. I mean, maybe less so with home care, but, there's maybe not, but there's going to be, you're going to gain a lot more understanding of what the priorities are and what needs are not being met once we kind of dissect those complaints a little bit more and figure out kind of where we could have the most impact in this community. I can't pronounce the word, but Ombudsman. Ombudsman. Okay, thank you. Yeah, sorry about that. I don't know, maybe I need another cup of coffee here, but that's really my main point that I wanted to say.
Thank you, Nancy.
Just kind of dig into complaints more. Yeah.
Yeah, I fully agree with you. And this is another reason that I'm really supportive of good data collection as part of this exercise, because I think that will help kind of drill in on some of that information. And I know I've been through hospice twice with both my parents, and being the youngest child by far, between 17 years between my sister and I, and 14 between my brother and I was like the baby that didn't know anything, apparently. And so it is really hard, and it's such a stressful time for families. And I want to make sure that whatever we do here, we are really there for all of our constituents, whether they are the power of attorney holders or just a child or a spouse or whatever. I would like, Maria, if you have any sort of comments or follow up from Nancy's points, I'd greatly appreciate it.
So to Nancy's point, one of the gap areas that we see that I'm not sure how much information we have on, I think we need more information, and Dorian might be able to chime in as well, that 18 to 60 age group where individuals don't have, we have protective services for the elderly, but we have a lot of individuals who need support, have care issues and concerns. And I do feel there's a big gap right now. And I don't know how where those calls are getting collected, or those kind of complaints, who's tallying them up. And to your point about data, I think that's a gap. I think that those individuals don't really have a place to turn at this point if they have concerns. There is Disability Rights Connecticut. There are other places that they can get some support, but not in the same way that an older adult can, like if they're calling in and it's categorized or classified by Dorian's group. So we do see that as a gap in our state. For individuals that are choosing, like I said, to be in the community and still need some support. So Dorian, I don't know if you want to add to that at all.
Dorian, you're muted, but I know you talked a little bit about this when you gave your presentation.
I did, and I think, Maureen, I think you're, reiterating the point that Connecticut is unique in that we do not offer support to adults with disabilities that may have these types of support needs. And, I think when we're talking about an ombudsman situation, we may be talking about a need for service coordination. And there is an overlap with protective services in that sometimes it is about linking to supports and care, or providing information and education about how our service system works. But then there are actual protective issues where folks are not getting their needs addressed or being overtly maltreated or neglected. And we in Connecticut fall short by not offering that as a state. So, we definitely need to also think about what can we do to protect others. And, I played in waiver land for a lot of years on the Medicaid waiver side. And one of the health and safety factors that you put in your quality plan is how you're going to address, critical incidents. And so some of that for folks that are on waivers fall under some of the case management activities. If folks are on the home care program, there are protocols to make referrals to the to protective services for the elderly. But if you fall in any of the other categories, there is no entity to provide protective work. So that is a challenge. But there is a need also for folks to just be greater informed. One thing that we're working on here at the Protective Services Program is partnering with the National Adult Protective Services Association on implementing a statewide education campaign about protective services. Not sure of the timeline. We're still, picking on what kind of symbols we want and the language, et cetera. So these things can be a bit protracted. But I think earlier points that were made, I think it was Diane that made the point about the importance of education and information about what's available is going to be very key. But again, we'll put in a plug for APS because I really do think that Connecticut falls very short in not having that.
Thank you so much. That's really useful information, and I'm going to be following up with you as time goes on, so to see how that communication program's going, because I do agree that it is really, really important, and we don't want anybody to fall through the cracks in our state just because they're not, small children or adults that are elders. So that we need to make sure that everyone is watched. So thank you, Dorian, for that. Mary Seeley, you've patiently been waiting. Chime in.
Thank you. I just wanted to bring up a comment about the, I think it was in response to Diane about how contacting and information if someone has complaints and who to reach out to. I know.
Mary, something happened with your volume. Can you try again? Maybe, not sure what happened. Yeah, we're still not hearing you. Is there anybody else? Oh, there we go.
Oh, okay. So they're given multiple contact information on that admission form, phone numbers, addresses as well, that they can access both while their family member is on service as well as afterwards, or even prior to discharge. If someone is going to be discharged for services and they're not in agreement with that they can appeal that. And there's also the patient and family bill of rights that's provided to someone at the time of admission. So ideally that's gone over with a family member and a patient. So someone is made aware of that. Also in regards to the outreach that's done, I know hospices that I've worked for, there's been a lot of education and outreach done in a variety of settings to seniors, with seniors, senior centers, directly to nursing homes, referral sources, physicians, hospitals, one-on-one in groups, provider to provider. So there's been an awful lot of outreach done and continues to be done. But I think what we're seeing over the years and continue to see is that people are waiting much longer to access services, especially with the advances in medicine, with the big palliative care movement now as well too. And, you know, what we're coming down to is people are having shorter lengths of stays on hospice, and it doesn't make for a good experience for the patients or the families as well too. And when Tracy mentioned the fact that there's all these other agencies and companies involved too, and that's a critical piece, because under the hospice benefit, which is a uniform benefit that any hospice agency has to follow, people are limited under that in terms of the amount of home health aid support. And that's something that families really rely on, is the home health aid, but they're often having to use these other agencies and companies that Tracy referenced to supplement that care, because families can't always do it all themselves, which is okay. And it gives them time to be family members, which is so crucial. But sometimes there's problems within those companies and the providers that they're putting in place. And the hospice role is limited as to what we can do with them, because if they're hiring these agencies, the families become the employers then. So we, you know, we can't intervene too much. Our role is really limited there. So just want to bring in a couple of those issues that are faced.
Some great points, Mary. Thank you so much for raising them. I know we have different bills of rights, families' bills of rights, patient bills of rights here. The federal has some bills of rights that really dictate what we're doing for long-term care, and the state has their own. And we would have to be thinking through of what, in a community setting, what those bills of rights would be. So that is something that would need to be developed, and we'd be thinking through that. Probably not specifically within the legislation, addressed specifically there. Although I will take advice a little bit if we do need to address it, but my understanding is that we don't. But again, communication and dissemination of information is so vital in this, so that people know what the situation is. Does anybody want to respond specifically to Mary's comments? Great. Okay, I'm going to move on to Diane Alora-Sala as her hand raised.
Thank you, Representative Dathan. Just wanted to clarify some things that have been mentioned with many of our previous speakers. First of all, in the minutes, I know that our previous speaker had mentioned that, because she wasn't at the last meeting, that we have agreed that there will be no carve out for hospice. That is not an agreement that I'm aware that we've come to a conclusion on. I know that Tracy had mentioned that she didn't see the need. I respectfully disagree. And I think I want to make sure that the public understands that whatever we call, and again, it's not just semantics, this office, should it be decided to add to it, that the public has access to the different specific specialty services. And wordsmiths there are ways of doing that. So I just am especially concerned that this important and growing need at home, hospice at home, will be kind of diluted and embedded in some other title. Number two, I think we're not reinventing the wheel, because this is a wheel that has lost air and is dangerously going to the breakdown lane. I understand what people mean when they use the phrase, let's not reinvent the wheel, but I think that this fine esteemed group is breaking new ground And of course, we don't want to duplicate services. And in fact, I think one wonderful benefit of this working group is to see who is duplicating services. But I think we're inventing a wheel that is needed to be reinvented. It needs to be invented, as we saw in the long-term care LTCOP report. And lastly, the issue of power of medical attorney, and there is a new phrase for that. That is what we want to focus on. And in the past, I have mentioned that I too was younger than my older sister, and that caused issue because I did not have access to important information, even possibly the flyer that Mary Seeley just mentioned. And maybe if we can find a way to tweak that so that, and I was responsible for some of my mother's care after we made that decision to enroll at home hospice. So I think we need to make sure that we maybe address that, but I don't want to sideline us. For the power of attorney issue would be, I guess, in the committees that look at this sort of thing. And I don't want to sideline Lucy's working group, but it is an issue that does occur. And lastly, I am also respectfully disagree. I think we do need better outreach and publicity about these wonderful services and all of the providers, as well as the families they need. So I guess I respectfully disagree with Mary. I think the outreach could always be better, right? So we maybe need, especially in a time of social media and our new electronically communicating, let's look at creative ways to do this outreach and get the support needed. Thank you.
Thank you, Diane. I think that's useful. Does anyone want to respond to Diane before I go on to Dawn? Dawn Lambert, I'd like to call on you.
Good morning. Just to underscore the importance of, from our perspective, I'm in Medicaid and I'm primarily responsible for the program that serves most people under the age of 65, which is Community First Choice now in our state. About 9 out of every 10 people served on the age of 65 are in that particular program. It's about 5,000 members. One, to Melissa Morton's point, absolutely agree that understanding what exists and also the roles and the responsibilities of each is important. To both Dorian and Maria's point, we do have a gap in PSE for protective services for the elderly, for people under 65. We have a gap in people's access to community ombudsman, not just for people with hospice, but across the board. Those are gaps. How those, whether or not those are the right places to start with resources, I don't know. But I think a gap analysis and clear understanding of roles and responsibilities could be a great first step. And then that becomes the basis for our education. So at least people know what we have and how it all fits together in a logical way, whether it's care coordination, because there's a role there as well, whether it's protective services for the elderly, whether it's the ombudsman. I think that's a great, and we're absolutely happy to help with that, if that's something that you would like us to help support. The other, just a footnote on protective services for the elderly, so that we all have the historical framework. The public that we serve in that program has very clearly in the past stated that the role of protective services for the elderly, or protective services globally, is they don't see the need to be protected as we might. Let me just put it like that. When you're a 50-year-old who's self-directing and you have your own employees, primarily you're hiring your own staff, it can feel uncomfortable to have an employee who reports to you actually be reporting to somebody else about what they see that you're doing that's unsafe. Mm-hmm. It takes away some of the degree of autonomy of that person who is on Medicaid. And it brings up that whole important discussion of who defines safety once somebody's on Medicaid, and at what point does someone on Medicaid lose those options to self-determine that each of us might have in our own house every day when there's not an extra set of eyes, government eyes, looking at what happens in our house. It's just a great discussion. I'm just saying that literally is what driven in the past the decision of the state not to engage in protective services has actually been from the people that we serve themselves. Having said that, Medicaid absolutely, as does government, role to ensure safety and health. Great discussion. I don't know if there's a right answer, but there are some tensions, as you can imagine, on both sides about where do we draw the line. So thank you.
Very important points. Thank you, Dawn. Rep McCarty has hand raised, and I would like to make sure that everyone who does have a question, please raise your hand. This is a great discussion.
Yeah, thank you very much, Representative Dathan. If I may just go back to some of the points that were made earlier in the discussion, I wanted to tell you that my reaction, what Tracy Waddick said, that was my first reaction as well when I read through the report that, you know, particularly in this time that we're trying to be very inclusive and not let anyone fall through the cracks. So I'm just wondering if you would permit and if we could talk about some consensus building within the working group to first identify whether or not we want to broaden this out, figure out exactly how, because the report does single out those various programs that we identified with the 25,000 people, but we understand that it's a much larger group that we could be talking about. As we went through the reports that you provided, and thank you for that, Maine looks like it does cover a lot of the areas that we've been talking about, including home-based services, hospice care, and all of those areas that I think this working group has been put together to look at. So I'm curious, and maybe you could guide how we could perhaps bring someone here from Maine or to join our Zoom meeting and maybe help us really delineate a little better how they handled all of the services, because I know just working with Mairead over the years in the long term, there are a lot of challenges right there. So, you know, while I'm supportive, I just would like to know if we could have a greater understanding of how they approached it, because I think Connecticut really does need to do work in this area. So I'm sorry if that adds, I don't want to slow the progress down, but I think we're at a point where we need to gather that information.
Excellent point, Representative. I think that's something I'd like to hear as well, and I appreciate you raising that. Mairead, would you have any ability to kind of see if we can get someone else in for a discussion on that from Maine, perhaps?
Sure, I can send an email to the state ombudsman in Maine and just ask a little bit about their process and see if there's someone that could speak to their program. Sure.
That would be great. And even if they can't come to the meeting, maybe they can kind of highlight some of the stuff that we can, because I do want to address that, because I think it is very important and very valid. And we want to make sure whatever we do really fills the need and not just is not doing something for the sake of doing. So thank you for that. Nancy Bolus.
Yeah, I like what Representative McCarty suggests, which is to kind of bring someone in who's already kind of reinvented a wheel, so to speak, and to see how things are working there and to learn from that, kind of benchmark that. And, you know, I was just thinking in terms of complaints, kind of what's the challenge of dealing with complaints. And I know Mary Seeley had made a comment about bringing in staff who kind of to support facilities that are maybe need people on board and kind of filling gaps and needs as they go along. I think it's a challenge with facilities who have operations in place and run things a certain way. And if they don't have permanent staff, but they have people coming in and out who, or there's a constant challenge of being short-staffed. I think there's an issue of having someone really getting them to listen and to be open to, you know, the input and embracing whatever an ombudsman has to say and integrating, making improvements. I think sometimes, you know, I'm sure there's facilities who are just trying to keep things going and are resistant to change. So I think that's a dimension to all this too, is once there is a complaint, and how do we get an organization to understand and embrace and move forward, shifting a little bit in the way things are done operationally. You know, that's always, I think that's a challenge. So I just wanted to make that comment.
Thank you, Nancy. I think there's some validity there that we need to be cognizant of that as well. Does anyone want to respond or follow on with Nancy's comments? Mary Seeley, I see you have your hand raised.
Yeah, I just wanted to clarify my comment about the other agencies. Is mostly what we see is that families are enlisting other agencies to hire home health aides.
Oh, I see. Okay.
That's what it is, right? Or additional private care support in the home.
Okay, thank you.
Clarify.
Thank you for clarifying, Mary. Nancy, do you have any follow on?
No, I just think there's going to be a challenge at breaking down any resistance to doing things a little bit differently and better so that the operations of a facility are improved. That would be it.
Well, this has been a fantastic discussion this morning. I would love to open up to my co-chairs to see if they have any follow-on comments before we talk about next steps. Brett McCarty.
Yeah, thank you again, Representative Dathan. No, I think we made, there were a lot of very interesting points, and I think we're all in concurrence that there's more work that needs to be done. I'm just, again, concerned about the scope and exactly where the need and how it can be implemented, because even with the report we received, we see it's very complex, and we've learned that. So I would appreciate, and I appreciate Mairead Painter always being so willing to reach out, but I think that would help us, because I think your intent in forming the working group was to try to be sure that no one was left out and that everyone had a voice and a path if there was a complaint. And while we're now broadening it out to the entire state, it is a little bit overwhelming, but I think it's necessary to find out exactly how it could work. So I would hope that we would gain a little more information from, I don't think there are too many states that have tried this approach, but it looked like from the reading that Maine was one area that we might be able to gain some useful information. But I think everyone made excellent points today. If you could try to determine if there is consensus there to broaden it out. I also forget which speaker mentioned it, but if the overarching goal is to reach everyone, but then there was one part of the comments that was made that said maybe a phase-in approach, but knowing that we're trying to expand to everyone. But I feel that Mairead is in the best position to really help us and guide us through this journey, because it is, to me, it's a good approach, but it's going to require a lot of work. Thank you.
Fully agree, Brett McCarty. I think this is, there is still some work to be done, and I really applaud Mairead for the willingness to help and get people served in all corners of our state, no matter their ages and what the issue is. So I really do applaud her for that. Brett Comey, do you have any follow-on comments?
No, I just, my head's spinning. So many of you really offered so much to the conversation, and I really appreciate that, forthcomingness about the issues and the knowledge resources that you bring to the table. And I think, we have a great team. It's well-rounded, and we can get moving in the right direction, continue moving in the right direction, and we'll just keep on keeping on, I think. So thank you for participating, everybody, and I look forward to seeing what we can do to find the resources to continue this work. Thank you.
Thank you, Rep. Comey. I'm going to open it up to see if anybody else has any follow-on questions or comments. Okay, Diane.
Yes, thank you, Representative Dathan. You had asked, is this the time to talk about next steps, or is that next on your agenda?
That's next on my agenda.
Okay, I'll hold my
okay.
comment. Yeah, thanks.
So next steps, what I envision is we will still have our December meeting, and I'd like to really talk about the topic that Rep. McCarty brought up about the expansion here, and whether we should be looking at that as part of any legislation we're doing. And I think modeling it on what other states are doing is very appropriate. We do need to be thinking about cost, and as Rep. McCarty and I are both on appropriations, this is something that's near and dear to both of our hearts. So we will like to include that as part of our discussion. I appreciate again, Mairead, for willingness to kind of look at this and making sure that whatever we do, we do correctly. I will go back to Diane. If you have any comments on next steps, I'd love to hear that.
Okay, thank you so much. This has been, again, another very great discussions of different people's backgrounds, experience, and training. As far as next steps, one thing that I think would be helpful to me, at least, and I'm sure others, is Teresa brought up a flyer that is given to patients upon home care. I don't know if it's just hospice care or if it's people that begin home. So the flyer that she was mentioning that's given to families or patients upon engagement, I would love to see a copy of that for the wording, and that would be great. I think that would be very helpful. Number two, any patient bill of rights related to the topic we're speaking of. I know I could dig into it with Google, but you all are probably at the tip of your tongue. It would be easier if maybe Heather can send that around to us in preparation of the next meeting. I feel that we need to refine our target and reduce the scope, because I believe if we're broadening the scope, that's where the amount of money will be so huge. And I'm already, I've read the report for the special act in 2019 that it's complex and it's going to cost a lot of money. I mean, I'm a former regulator, so I know what that really means. And I'm concerned that there are many issues that have been brought up here. But the original reason we came together was because of the increased home health care and hospice care. Home, not facilities. Now, indeed, there are issues with facilities. And I really appreciate fellow Norwalker Nancy's comments, because she and I spoke over last year, the year before, about this whole issue. The thing is, though, there are mechanisms in place to fix those things. I would like to see a separate bill, perhaps, for that. I'm afraid if we lump everything together, it's going to be turning into what typically happens in a short session, which is let's do a study. And I haven't spoken with Representative Dathan. I know it's a short session, and I know that the money is very important. But I'd love to make sure that we try to begin resolving the issue of the explosion of home healthcare and home hospice. So I just wanted to leave you all with that thought. That was our original reason for coming together. And I know there are issues with enforcement of the licensing. I know there's other issues, but I feel that it was clear what our original plan was, and I'm seeing us kind of do a little drifting myself, but that's just my opinion. But thank you again.
I think valid concerns, Diane, that you're raising here. And I think my view is we have a meeting scheduled for December, and I think it is well worth exploring that if we need to expand this, and maybe the implications, and maybe it is we go away from the meeting and say, you know, this is an incremental step that we address the community home care hospice ombudsman, and that we have follow on and additional work that needs to be done on these other issues. But I don't want to lose sight of, you know, these other members of our state that might not be getting the attention that they need. And I think we owe it to them to have that conversation and carry on. And whether it's appropriate for the legislation or not, that is part of the discussion. And so you know, we do have the date scheduled and would love to carry on with that discussion if we can, and then decide at that meeting what is the most appropriate next steps. Does anybody, Rep. McCarty, did you want to add on to that?
No, and I certainly concur with your remarks, Representative Dathan, and I would hope that the previous speaker didn't think from our comments that we were losing sight of why we were brought together, because I do believe the looking at hospice as part of the community ombudsman program is very important. But that's why we're asking to see what the other states are doing so we can get it right. So no, I agree with what you're saying. Thank you.
Thank you for your support and your comments and what everybody's bringing to the table. With that, I am going just to announce our next meeting, December 16th, 2021, 10 a.m. via Zoom to carry on this conversation. Diane, I will be reaching out and trying to get a copy of that flyer. Sorry, I forgot to mention that. And we will add that to our list of to-dos. And then, Mairead, hopefully we can connect with somebody in Maine to bring them in, if possible, to that meeting to have this follow-on discussion. And my hope really at the end of the meeting, the next meeting, is that we will be able to kind of finalize our findings and be able to address this in legislation. We do have a short session, so that does make things more of a challenge. Just to add here, I've had great conversations with the chair of the aging committee on the House side, and this is something that Representative Phipps, is very supportive of, and really would like to make sure that we do this well. So I know he's couldn't make today's meeting because of a prior training that he had scheduled. So hopefully he'll be able to join us at the next meeting and kind of talk a little bit about next steps with any legislation that we have on that side. With that, I'm going to ask if anybody has any final closing comments.
Representative, I just wanted to let you know that I already sent the email to Maine, and as soon as I get back an answer, I'll shoot that over to you and Heather.
Oh, wonderful. Thank you so much for being so efficient. With that, I hope everyone has a lovely afternoon, and I hope everyone has a wonderful Thanksgiving, and there's a lot to be thankful for this year. And hopefully we all can make the meeting in December. I know December is so crazy with the end of the year holidays, but I do appreciate everybody's time and energy to help resolve this so that we can really make headway in the next legislative session. Have a good afternoon, and we'll see you in December. Take care.
Thank you.
Bye-bye.